dislocations. And this is the bugbear of most of us who do hip surgery. We've got an excellent panel here to discuss the pros and cons of.
I think for some reason, Ronan got disconnected. Ajit, you would like to carry on? Maybe you can welcome on behalf of Ronan.
Yeah, sorry. So there's some technical hitch there. So on behalf of the Indian Arthroplasty Association and the Indian Orthopedic Association, it's our privilege and pleasure to invite you all for this webinar. And without much ado, I hand you over to the convener for this evening. It's Dr. Anil. The topic has already been mentioned. It's the dislocations post THR, one of the major problems that has major consequences, both in terms of managing the patient as well as the economic impact on the patient. I think Dr. Ronan is back if he wants to say something.
Thank you, Ajit. Ronan, you like to...
Actually, I mean, just go ahead.
Right. Thank you, Ronan. So this webinar's convener is Dr. Anil Lumen from Vellore. And Dr. Anil has chosen the faculty and the subject very carefully, which is a subject of common importance for almost all the orthopedic surgeons. Even if somebody is doing a bipolar hip arthroplasty and not a regular arthroplasty, even for them, it is a very important subject. So I'll hand it over to Dr. Anil Lumen to carry it forward. Anil.
Thank you, Dr. Rajiv. Thank you, Dr. Ronan, and everyone for giving us the opportunity. I think this is a very important topic, and the minute dislocation is mentioned, or even a call we get for one of our patients saying the hip is dislocated, whether it's a hemi or a total, it's truly a humbling experience, and we set our minds thinking we are literally on all fours thinking what went wrong and what could have gone wrong. And I think it's a humbling experience for everyone, no matter how experienced or how senior we are. We always go back and think what we could have done better, or what could have happened, what could have gone wrong, and what we didn't actually analyze. So I thought this was the best opportunity to get some very good senior faculty on board. And I'm glad that in spite of a last minute request, Dr. Suri, who will be able to, put a good introduction, like the opening batsman to this topic, a good crisp view of what is dislocations and what is this thing. I thought this is an apt choice. I handed over to Dr. Suri to give our opening talk on dislocations in total hip arthroplasty. Over to you, sir. And thank you very much for joining.
Thank you, Anil. Thank you, IOA. Thank you, the Indian Arthroplasty, Dr. Rajiv, Dr. Ronan, Dr. Ajit. It's always a pleasure and an honor to be asked to set the ball rolling here. I'm just sharing the screen at this time. Can you see my screen?
Not yet, sir.
Okay, there I'm doing. Is it fine?
Yes.
Yes, it is.
Yes, sir.
Now.
Yes, sir. Please put slideshow and go ahead, sir.
Yeah. So I think the topic given to me was dislocation after total hip modalities, possible causes, and intraprosthetic dislocation, which is the new mantra we have to start addressing it too easily. We all know about what are the at-risk group for instability and dislocations. I mean, commonly we talk about the standard elderly, the high BMI, cognitive dysfunction. And the newer consideration, which is now slowly getting better and better understood, are the spinopelvic considerations. I think we can't escape it today, that every hip done, I think one should have some data about the standing, lateral, standing, flexion, extension issues, etc. So far as the neuromuscular issues and the post-op protocol, gender, etc. is concerned, if you would scan the literature, the evidence is mixed. But one thing that is remembered, the punch point here is that the re-revision for instability following revision for dislocations is 35% over 15 years. So I think it is a constant worry. It is not immediate. We all talk about the immediate dislocation, but what happens down the line again is as important. Following multiple procedures for the hip, again, the dislocation rate jumps extremely high. So almost very important is identifying the cause of instability and dislocation. The Easiest is to identify the component malpositions and the standard issues. But I think one needs to be more precise now. It is not just hip alignment, component position, length and offset. I think it becomes extremely important. Impingement, I think it comes early or during the course. Contractures and laxities, if you see the neuromuscular issues. Most important, abductor discontinuity or abductor injuries and its function or dysfunction, and the spinopelvic issue. So we'll address one aspect after the other. I'm taking certain things for granted because I think we have an audience probably that well versed with all the other basic data. Does surgical approach affect the total hip? This was probably a point of discussion earlier on, but today I think this is done and dusted. And we know that all the approaches have similar dislocation rate. And so follow the road that is familiar to you. You don't have to specifically change your approach patterns just because you are scared or you are concerned about dislocation. Of course, anterior lateral approaches come. The direct anterior is now there available for us, and they have this. One thing important to understand, dislocation is a permanent risk in the life of both the patient and the prosthesis. This is just a classic example. This is a 23-year-old lady post total hip, 23 years later, 78 at this time. The cup was not a very highly well placed, but it was slightly adducted. It was a 28 head. She continued though for 28 years. And after that, she dislocated. What was the cause for the dislocation? It is besides what is obvious, what we see, it is also important over a period of time. That is recruitment of other causes like weakening of the muscular tone, penetrative wear in the poly, especially the conventional poly, besides the rheumatoid. So these things get recruited over a period of time, and that can contribute to the dislocation. Another small example in this case, this is a 73-year-old lady, 17 years post-injury. This was a series 300 Duralock cup, which I think done in somewhere else in Mauritius somewhere. But then she came at every time she got up, she was dislocating. And if you look at it, what was happening basically in her was that when she starts and then the hip just impinges, the neck impinges over the anterior part of the neck and this dislocates. See the slide lower down and you realize that there has been some penetrative wear. There is a gap and the proximal medial migration. And this probably what leads to your early impingement with this short neck 28 head. So this penetrative wear and impingement, of course, was a concern a lot in the earlier conventional poly with the 28 and 22 heads. But probably we are out of all this, hopefully, with the use of larger heads and the cross-linked polyethylene. Maybe less of a worry, but it is a mechanism that is what is concerned here. And all that this lady required, even at 17 years, was just change the cup, the poly. And this time I was fortunate that we were able to, DEPI was able to supply us with a 36 liner and with the 36 head. And you find the stability is extended, the range of motion extended, and the joint was stable. So this is, so long as you dissect the cause of the dislocation, I think we are in safe ground. We exactly know what we need to address to. Maximize the head side is the one lesson that we learned from the previous case, because the lower cumulative risk of dislocation over the long and a better impingement function is much higher. And the current cross-link polys enable us to get a larger head even in the smaller outer diameter of the cups. Depending upon the industry partner you use, you can get. But does that mean the large head allows us to malposition sockets? Certainly no, because this can again impinge at various points. So large head is no substitute for malalignment. This is for the people who think that the dislocation will be less just because you put a large head. It's a no-no. I think the basic fundamentals do not change. Your alignment positioning has to be exactly the same what you do for this case. One point additional is in the revision scenario, when we use a larger and larger cups, what sometimes we call the jumbo cups. I put that word small because I think it is just a relative term. It truly is not an implant or a size. The jumbo cups defined in literature is not true in the Indian scenario because our outer diameters is not 62 and 66. When you have these oversized cups, what happens invariably is the inferior part impinging either on the psoas tendinitis and the Crohn's pain, or impingement at that spot, and this can be a serious cause for dislocation. So beware of this case, of this issue. When you take, probably you may need to abduct the cup a little more and avoid too much of an extension on the inferior side. So talking about impingement, what you have to clearly understand, it's a terminal mechanism in many situations. It is not the sole cause, but it could be a mechanism at various points during the life of the prosthesis. It could be between the components, malposition, or a very poor head-neck ratio design in the design. It could well be also the osteophyte, cementophyte, pelvic impingement, soft tissue impingement. So to avoid all this, I think one thing we need to get it clear at the end of our trial implant or the final implant is assess for intraoperative stability, that is hip adduction and knee flexion. That is the typical position which you take in the lateral functional position, sleeping in the lateral position, that there is no adduction or impingement on the anterior inferior side. Hip abduction, external rotation, get off the car. This is the position you take when you swing your leg out. So make sure there is no abduction between the tip of the trochanter and the superior part of the acetabulum. Flexion, internal rotation. Again, when you crouch down to where, again, you should not have any impingement that is on the anterior inferior side. It could also be a soft impingement here. Deep hip flexion, getting up from the low seating. Again, we have got to be careful that we don't have, again, the anterior soft or a hard impingement. Assess a lesser trochanter to the ischial tuberosity impingement in external rotation, or the capsule to the anterior inferior iliac spine. So this is just for us technical tips or the points that we need to address when we do this. Malposition often probably is easier to find. Sometimes these malpositions can be very subtle. And if so, if need be, I think you must resort to a CT scan, identify the component alignment, component position. Like, for example, if you see end-on a clear AP view, probably you are just neutrally verted, you are not anti-verted. So this needs to be studied better on the CP because all this will require a change. This is again one case in example. This gentleman at 10 years, the stem had subsided. This was a Schweimeller stem, which had subsided earlier on. And obvious is the stem subsidence as a cause of pain, and she was revised. And when this case was revised and it all appeared good, the acetabular side was not revised for reasons that it was intact and not giving any problems or no lysis. But this subsequently, the patient dislocated repeatedly twice in the next 3 weeks, which brings us seriously to two questions. Address two issues. That is one, if you see proximally at the lumbocervical junction, there is some spinal instrumentation that has been done. And the acetabular side, if you see the surgeon had missed it, the acetabular is neutrally verted or probably slightly staring at you, mildly retroverted. So I think what is the lesson in this case, what is analyze completely both elements. Do not take anything for granted. Don't focus only on the obvious, focus on the not so obvious. So I think because oftentimes decision or dislocations are multifactorial, and this is a point we need to mind. Bone, acetabulum, femur, the soft tissues, all across is necessary. So that brings us to the question of dynamics of the socket placement. The standard assumption is if you have put it in anteversion and abduction of 30 and whatever degrees with a combined anteversion of 35, I think the socket position is static and constant. It is not so. If you look at the pelvic fixation or overall, that is only a static position of the cup anteversion. When you see the activity of crouching down in further inflection, the pelvis goes into a pelvic sort of a retroversion here, and that will increase the anteversion angles. And if it is aligned or slightly malaligned, that could lead to probably a dislocation. So pelvic motion changes the version and inclination at all times as the patient starts moving. So I think this is a point, this is entirely a subject by itself, the spinopelvic parameters and the compensatory mechanism. Suffice to understand that from standing to the sitting position, if you see, which is the commonest uniaxial movement besides the rotations, the spine starts flexing. That leads to posterior pelvic tilt that will increase the anteversion. What is the role of this anteversion? Why should it increase? Because that then accommodates the thigh. And the sitting position accommodates, if that is going to be an anterior impingement between the obese patient, between the thigh and the abdomen, that can again be a source of dislocation. And for the mathematics, 1 degree increase in the pelvic tilt will be 0.7 to 0.8 of the increased functional anteversion. So this is what we try to adjust it. So what is suffice to say that how can we quantify? Radiologically quantifiable factors for mobility and stiffness look at only the pelvic plane, the anterior pelvic plane, and the sacral slope. I don't want to complicate it, just to make it very simple. If you have an increased posterior tilt, that is a greater anteversion is required. If the anterior tilt of pelvis, decrease the anteversion. This is very, very much in a small nutshell. There's much more to it than this. These things become important when you talk of fixed pelvic situations, especially orientation adjustment. There is a voice issue.
or replacement.
In fixed pelvic situations, I think we need to worry
All
about
parts.
study and control the.
Tip job hai?
This is one case similar in example, a acetabular dislocation, fracture dislocation, operated, and all looked good. But in about 3 months' time, it sort of just walked out and dislocated and was recurrently dislocating. Though the socket and the stem position seemed to be in the safer zones, this was a clear example of a soft tissue instability. This is one thing which we need to worry about in the multiply operated cases, in trauma, in neuromuscular issues, that the components could be stable, well aligned, but the hip is still unstable. And this case was a partial abductor insufficiency, which is a common cause and sometimes can drive you, especially in multiple revisions and disruption, and this needs to be subsequently revised. I just put the clinical picture of this gentleman because he did very well for 5 years until, just as a tribute to him, because COVID took him away about a few years ago. But then with this simple reconstruction, he had done extremely well. So abductor issue is a factor we need to consider in erosive destructions, post-fracture and multiple surgeries, sometimes in the Harding approach, if not done appropriately, and iatrogenic cases. So these are the situations, worry about dislocation. So recurrent instability in patients with poor bone stock and inadequate abductor tension and tissue still remains a challenge. When you have such situations, not only the reconstruction, not only the realignment, but use of system constraints seem to be important and is the way to go today. And in fact, historically, formerly, we used to have the 22 Charnley cups. And then when they were repeatedly dislocating, we used to have a superior extension with screws. I mean, this was just a very colloquial way of doing it. But today we have the constrained liners and the dual mobilities. The dual constrained liners more or less has given way to dual in most situations. Very common, it was nothing new, initially used by the French for both primary and the revisions, introduced in the late 70s. Again, was to address the dislocation, but the benefits well accepted today worldwide. And as a case example like this, when you have a total deficiency of the proximal, we need to add system constraints in these cases. So abductor deficiency in megaprosthesis, large prosthetic lever arm, these subjects are there's a high propensity for subluxation and dislocation. One should worry about it. But whenever you have an additional sort of a support available or a material it's available, there's nothing like a free lunch. There is always a trade-off, and somewhere it probably is going to hit you, and one needs to be paused. So when you use these dual mobility systems, again, a subject in itself, just addressing the intraprosthetic issue, there are reports of the early rates of early intraprosthetic dislocation with the dual mobility, either the dislocating both with the plastic liner with the head or the head coming out of the plastic. And initially, the reported dislocation was basically because of the wear of the conventional poly. Hopefully, that is addressed with the cross-link polyethylene. But the Australian registry again has shown that the replacement or the dual mobilities have a slightly higher. But if you dissect this paper, what you find the increased revision rates is because all these are high-risk cases. So maybe universally, probably it may not be the true story. So intraprosthetic dislocation is basically a wear of the third articulation. When I say third articulation, we have a convex and the concave side of the plastic, which articulates on the metal shell. And then when it comes to the extremes of motion, initially you exhaust the inner movement, concave movement, and then the convex movement takes over when the neck impinges on the plastic. When that happened, this had been the source of polywear, and this has been the reason for the intraprosthetic when it slowly started wearing out and the head escaped the confines of the head. That is why today you sort of literally pump the head into it. Initially, the problems are large necks, non-round surface, skirted metal heads, but these are all have been taken care of. Modern the dual mobilities have addressed to this, chamfering, suprahemispherical coverage, and on the table, in the back table, you put the head in. So repetitive impingement of the neck on the polyethylene rim is the main reason for the where a loss of the retentive mechanism and the femoral head escapes, and these needs to be addressed. This is one such example we ourselves saw. That is, you see the oblong shape of the poly inside. This sort of wore out, and the head escaped very easily from this, and then this dislocates. Failure of retentive, I think failures slowly is coming down. Use of a large head, maybe 22 or a 28 head, seems to be more appropriate with a less degree of dislocation. Cross-link poly addressing the design issues of this neck and the conducive neck designs and the constrained head capture have made this less. So in conclusion, I think talking about dislocations, restitution of ideal anatomy is very, very important. Do not use even a dual mobility or any system to compensate for the cup malposition. Fundamental is to get that aspect right. And then you use the other options to further augment the stability. Instability still remains the challenge. We need to use multiple options. Several surgical options are available alone or in combination. So use all this together and not one single aspect. The major influences today which can limit and avoid and help us are the head sizes, larger head, cross-link poly. I think the conventional is now out of the window. Dual mobility systems in case where you find the need. Whether we should use in all cases is a big question. I think that is still open. Offset options, if required, is to do so that you restore the anatomy or the morphology of the system completely. Today, I think we can still use the positioning devices in difficult situations so that you can even, like with the robotic hips, you can get into where it impinges and accordingly you can reposition the cup and understanding and the surgeon experience faces. Functional impact and the spinopelvic issues today is the mantra. We need to study it more. Wherever there's a repeated dislocation or the potential possibility of dislocation, we need to judiciously use this appropriately in terms of realigning the socket and then use the other constraints possible. Thank you.
Thank you, Dr. Suri, for that, I think, overview of the causes. And I think you mentioned very well about the intraprosthetic dislocation. I think just a quick addendum while Nikhil gets ready for his presentation. I think Nikhil wanted to present because he had to leave. We can take one or two questions. We have about, we can take one or two questions. Any burning questions? Or definitely, Dr. Suri, you'll be there till the end, right? Because we will have a discussion at the end. Is that okay?
Sure.
Yes. Any burning questions? Anything right now? As Dr. Nikhil loads his presentation. Dr. Suri, quickly to ask you, what is especially the intraprosthetic type of dislocation? Are you seeing that with a particular with a particular set of designs, or are you seeing that more frequently now?
We have seen only one at this time.
Okay. Because
but
even
I think it's a very point you have raised, a pertinent point. Before every dual mobility is not the same. All dual mobilities are not the same. I think we need to study into what is the given, what is the bevel, and how much is the capture, whether it is an extra 180 sort of a cover, over the top cover which we have, what is the material, and what is the neck type and dimension, what is the offset. I think many issues, there are a lot of design issues we need to go into before just randomly taking something in. You are very right.
Thank you, sir. And we will carry on the discussion at the end. Now over to Dr. Nikhil, who will
can you see my screen,
Anil? Yes, Nikhil, go ahead. Please put in as, go ahead.
That's great. Thank you for the invitation. And it's always a tough order to follow Dr. Surya Narayan. This is mainly a case-based discussion. So I will look at two specific scenarios and surgical techniques where a dislocation can be solved by these two unusual solutions. So this gentleman had a malunited femoral shaft fracture. He was in his mid-60s and he had arthritis of the hip. The surgeon had treated the problem using a long ZMR stem, osteotomy, plating of the osteotomy at the same time, and a metal-on-metal hip replacement using a Durom resurfacing cup. The patient did quite well with his hip for about 6 or 7 years, but then unfortunately developed adverse reaction to metal debris. And so I performed his first revision for ARMD. So when I went in, what I found is that the acetabulum was significantly retroverted, but he had not dislocated. What the surgeon had tried to do, or it could have been because of the rotational malunion of the femur, that the stem was very antiverted. And somehow the combined version was good enough that he did not dislocate. So when I corrected the acetabular version to what I normally put into, which is antiversion, post-operatively, the patient started impinging in external rotation. The hip was stable during surgery, and I always checked for impingement. I always checked for combined version. But when he stood up, clearly it was impinging in extension, and he started dislocating quite easily. At that time, it took me a couple of hours to figure out what was happening. And basically what was happening is you were getting this component to component and component to host impingement in external rotation and in extension. So always get a CT scan, especially when you have done the hip, and try and figure out what's happening. And you can see on the axial scans that in external rotation, the component is impinging against the socket and also against the bone. So this was a challenging thing to sort out, because that ZMR stem was solidly ingrown and about 290 millimeters long plus the body. So removing the stem would have probably ended up destroying the femur and a long extended trochanteric osteotomy. So one of the devices that we have on the shelf is called the BioBall adapter system. It is distributed by Lima. So what it consists of are these trunnion sleeve adapters, and you can get them in neutral version, or you can get them so that you can antivert them up to 7 degrees change of version. They can match most known taper combinations in the world, like 911, 913, 1214 or 1416. And you have to make sure that you know the trunnion of the underlying stem, and then get these trial adapters and the real adapters. And then they have ceramic heads that go on their adapter. So luckily we have this on the shelf, and I was able to solve this problem by using one, the BioBall adapter, and two, what I did is the cemented liner inside the trabecular metal shell, I intentionally, very slightly change the version of that liner. So you can see on the lateral X-ray how the angle of the trunnion is seen by one of the red lines, and the other red line shows the angle of the BioBall 7-degree adapter. And using this fairly simple solution, I was able to solve the problem. So this patient is now reaching 6 years without any problems. One of the concerns, obviously, is that you're increasing the number of interphases because of the trunnion. And this was also my concern when I did this for the first time. But BioBall have got data now. I think more than 1 million of these have gone into patients. And so far, there has not been any significant problems with trunnianosis or further adverse reaction to metallic debris or corrosion issues. So that was the first case. The second case is this device called the posterior lip augmentation device. I think Dr. Suryanarayan mentioned this briefly in his talk. So I'll show you what it is. So this lady was 67 years old, and she came to me with an acetabulum and a femoral head fracture in 2007. This was one of my first cases of acute fix and replace. So probably before even the word fix and replace was invented. The problem, of course, that she was morbidly obese, but she had a very small socket. The outer diameter of the socket was only 42. Now, one of the things that Wroblewski had manufactured at Wrightington is this offset bore cup. If you look at the X-ray of the hip replacement, it looks as if there is inferior wear, but it's not inferior wear. It's just that the polyethylene is much thicker at the top of the cup than at the bottom, so that the bore or the hole inside the cup is offset towards the lower part of the cup. And this is a very neat solution for these tiny sockets where you want to use a cemented socket. And my primary hip replacement remains a cemented total hip replacement. She was absolutely fine for 13 to 14 years, and then she started dislocating. So she developed 2 dislocations. I thought that she might be wearing it out, but there was no evidence of wear at all. So I did an examination under anesthesia because she was also getting subluxation. And basically what had happened is, because of the loss of soft tissue tension, and as you become older, the muscle tone reduces, there was some slackness of soft tissues. Now, she had multiple different medical comorbidities, and really the anesthetist was quite concerned about her ability to tolerate a major component revision. So this is where the PLAD comes in low demand patients, elderly patients, patients who have a lot of medical issues, and you want a fairly quick 30-40 minute operation. So she had diabetes, ischemic heart disease, transient ischemic attacks, and a variety of other problems. The other issue, of course, was that she had a very small socket. So you can't really use much of a larger head. None of the constrained bearings fit inside such a small socket. Even the G7 has got limitations. And certainly even the smallest dual mobility does not fit. I thought of getting a custom dual mobility manufactured, but the French company said that they were not able to manufacture such a small one because the manufacturing tolerances would not be considered safe for implantation. So this was what we did. This is called a posterior lip augmentation device. It consists of a metallic plate, and then it has a polyethylene plate attached to it. The screw goes through the metal side and the poly touches the poly. And if you see, what it does is it extends your posterior wall essentially and prevents the hip from coming out by causing something that is similar to a lipped liner. And you can put it posteriorly and superiorly, or what you can do is during surgery, check where the hip is coming out and you can put the plaid over there. Now, because she was slack, what I did is I did it like a full ring, like a circle of plaid. I put postoperative X-ray looks, and it was a fairly easy and a quick operation. The time that is required is for you to open and close the hip, and to put the plaid in takes about 15 to 20 minutes per plaid. And that she is at 2 years. She's now 82 years of age, very happy. She can look after her cat. She lives independently, mobilizes independently, and she's not had any further dislocations. So in conclusion, I find CT scans very useful to analyze component malpositioning. I think impingement is a very important concept, and you have to really understand how impingement happens. Examination under anesthesia before surgery is also very useful to look at what the stable arc of movement is, in which particular direction you're getting the impingement, whether it's inflection, adduction, internal rotation, or whether it is an extension and external rotation. And that gives you a strategy to perform your revision surgery. Before you plan the revision, it's important to understand the cause of the dislocation and to try and rectify those correctable causes that you can identify. It's very, very, very important to check for impingement. In fact, several years ago, when I first understood the concept of impingement, I realized that you can actually get away with mild degrees of malpositioning of the components so long as your combined version is satisfactory and you're not impinging. And then all the other fancy or newer strategies such as dual mobility, constrained bearings, they can be implemented where you don't really find a correctable cause. And bioball and plaid are very useful devices to have in your armamentarium when you're revising these cases. Thank you very much.
Thanks, Nikhil. I think that was good 2 cases, good take-home messages. I think Ajit is next online. So as Ajit gets his presentation ready, Dr. Ajit, any questions for Dr. Nikhil? Because I understand Nikhil has to leave. Will you be online or will you be leaving, Nikhil?
I'll try and join on my mobile, on my hands-free. I've got to get to my son's school.
Okay, no problem. No problem.
Can we just ask a quick question?
Yes, please.
I mean, the bioball concept sounds very interesting, but what was even more interesting is that it hasn't generated much metal debris. Any particular reason for that?
I think the manufacturing is probably satisfactory. One of the problems with tranionosis is often what you had is large cobalt chrome heads on soft titanium stems. So with the bioball, we have not really seen that problem. And I think it has got to do with better manufacturing quality, better matching of the taper. And that was one of our most important concerns. As far as possible, we try and avoid using the bioball, especially in young people. And I prefer to use it in sort of elderly, low demand people. But in a case like that, to take that ZMR stem out and that plate in that malunited femur, I think it would have ended up destroying the whole femur really. So it's an evaluation of costs and benefits to the patient, a risk benefit analysis before you decide what you want to do.
I mean, really bailout options in an extreme scenario.
I think so, yes, correct.
Nikhil, just one point. You knew it was a ZMR before going in, right? You knew it was a ZMR before going in. Any role for just replaced and repositioned and realigned the proximal bit? Just a quick question.
We explored that, and we had the kit available. but
Okay.
even the proximal bit was so solidly bonded.
Because that would have
And one of
required a
the,
short ETO.
yeah, so I could have done a short ETO. I could have used the mechanism to take that out.
Dislodge it,
One of the
correct.
concerns that we all thought is that it has been in for some while, and during removal or breaking that Morse taper, if that trunnion is damaged, then essentially, I'm stuck. Then I'm obliged to go
Sure.
after the whole stem. And I have seen cases where during
Right.
removal of the Morse taper, the trunnion does face some damage or gets scratches. And then that would probably be a much bigger problem. So my philosophy is go for the solution that has the least risk and it has the easiest way to solve it. Keep it simple.
Yeah, definitely.
And
One more
Nikhil,
question. I think we'll
your
ask-
second case, yeah.
Sure,
Or
Dr.
maybe
Rajiv.
we can ask you when you are on the way, right?
Yes. Okay. Nikhil, we'll get back to you because there's some questions. I don't think it's available as yet in India. There's some more questions that have come in the chat box. And I think the first one would be for Dr. Suri. Up to what range of motion do we check for impingement? That we can get back going later. Let Ajit get on with this case. Over to you, Dr. Ajit.
Yeah, you can see my screen?
Yes. Go ahead.
Okay. So, yeah, mine is probably more discussion would be in the initial stages, how to get it right, maybe, rather than how to solve the dislocation. So, going forward. Just one moment. Screen is not moving forward for some reason. Yeah. Okay. So this is a 63-year-old male. This was about, I think, almost 9 years now post surgery. So he had some childhood sepsis, and he had pelvic supportive osteotomy done at that stage, at that age. And then he was hobbling around all his life, and this is how he presented with pain, both in the hip as well as in his lower back when he came to us, and he wanted something done about it. So obviously he needs a subtrochanteric shortening osteotomy to get the hip center sorted out. But in doing this, I mean, whatever literature that I've read or seen in the past, they talk more about the nerve problems and the limb length problems. And hardly any literature talks about dislocations in this particular situation. So can I ask the panel any experience or any thoughts on this right now? Or should I finish my presentation?
You can, I think...
because the management part of it is not a long one, really. Any experience with the dislocations in such scenario, like with the Crow type 4 DDH?
I think the dislocation is a big issue in these cases because you have to release a lot of proximal femur, and most likely you have to do a subtrochanteric osteotomy for these cases. So I think is not uncommon in these situations. So one has to be more careful in these cases than the normal total hip.
Actually, in these scenarios, I think Krishna is also there. I think in these scenarios, when you do a subtrochanteric, get it right, the soft tissue tension is really good. And if you put it well, and if you get the hip center also restored, the dislocation rates are actually quite low. In fact, because the tension is so good, because you've done a subtrochanteric osteotomy to get the tension. I think that's what we've seen.
Okay.
Right.
Krishna, any thoughts?
One reason for that, Anil, is that these patients obviously will need a more care, more rest, less normal functions as against the normal hip arthroplasty. So that is also one reason that, and if it is rightly cup is rightly placed, the stem is rightly placed, then obviously the dislocation rate will be lower.
Anil, can I add something?
Yes, Dr.
Yes,
Anil.
Yeah. So we had one such case where patient was operated elsewhere, came to us dislocated. This patient had gross rotational deformity in the lower limb. And this patient had a deformity in the lower part of femur as well as tibia, gross external deformity, which surgeon did not take into consideration. So with what you said, with the osteotomy, subtrochanteric shortening osteotomy, I think we need to take into consideration these gross rotational deformities as well. So that case was solved by putting into correct rotation.
So the issues would
Yeah,
be
I
more.
think rotational alignment is very important. Go ahead, Dr. Ajit. And I think Sanjeev's question will take.
Anil, Sanjeev has a question, I think. Yeah.
Yes. I was saying Sanjeev will take at the end. Okay, Sanjeev, go ahead, Sanjeev. Hi, Sanjeev, go ahead.
Yeah. I don't have a question. I have just like basically you use the most modular implant in these kind of things, especially on the femur side. You can, as you correctly say, the socket is always brought down and center of rotation is maintained. But at the same time, with those proper modular implant, you keep it in proper versions. I think chance of dislocation is practically rare.
Yeah, modular implants to correct the version and everything. Go ahead, Ajit.
Yeah, so that's his lateral view there, just to get an idea about the thing. So yeah, went ahead and did that. I'm used to using this particular stem really. So did this, he was fine, discharged on the 5th or 6th day. And then he came back for suture removal at about 2 weeks, I think. And he was due for follow-up at about 6 weeks time. And yeah, about a month or so after the suture removal. And the night before he came to me, this was the situation. So anything obvious on the X-ray that could have been done better? I'll just put up the, yeah, here.
We need
It
to
looks
see
like a solution stem.
Yeah, it is a solution stem.
And it looks like a well-fixed stem in the femur, distal femur. Like
version looks a bit iffy. I mean, I'm not sure whether it's a true AP, but
the stem version or the cup? The cup.
Cup version.
Not able to comment on the stem version because I'm not sure, Ajit, what the stem version was like. Because with the solution, it's I'm pretty sure. What was the fit like in the proximal fragment? What is the fit like in the distal fragment?
Very good, very tight. There was absolutely no issues there. And on table, all the movements were perfectly stable. Flexion, adduction, internal rotation, external rotation, all of it was very, very stable.
What was the restoration of length like?
Yeah, he was short by about 2 centimeters even after the restoration of the hip center. He was about 6 centimeters, I think, initially, and he ended up about 2 centimeters short overall.
Dr. Avi, did we get a CT scan done for this later on?
No. This is the first dislocation. So my first thought was to straight away get him to the OR and reduce it. You can see that the osteotomy has not yet united there. Okay, so there's no malrotation or anything happening there. So I think most of us, the first dislocation that happens, we would take them to the theater, reduce it, reassess on table what's happening. And again, I found that on table, he was perfectly stable, right? There was no, in any major directions that I put the hip through, he was stable. And so did not do any further imaging or x-rays. So yeah, just thinking what could have been the reason for that.
Ajit, when you took the patient for the reduction, open reduction obviously was done.
Yeah.
So did you see it was a closed reduction?
Closed reduction, yeah.
So in the first surgery, was there any impingement?
Nothing.
Because of the osteophytes, no.
Nothing. All that was sorted out. I can just go back to the picture there. It was all cleared up, and even all the pre-op, there was nothing there. Yeah. So
you did a closed reduction or open reduction, Dr. Ajit?
Closed reduction. It was a closed reduction. Okay. It was very stable. And as far as I'm concerned, that's where the story ended, because it's now 9 years post procedure, and this is him well united. This was at 10 months follow-up, but this was in 2014 that I had done this patient. So I was just wondering what could have been the reason. Actually, what he told me was he was trying to get out of the bed, and he sort of hyperextended the hip, putting the leg out. And that's it. That's when it popped out. That's what he said.
So it is positional, I think.
Positional, yeah.
Positional, dislocations are usually if they're stable, then they continue. There should not be a problem.
So I just brought this up for discussion whether in these high dislocations, and particularly when you do the subtrochanteric osteotomies, whether there will be any issue with your soft tissue tension, because your placements, cup placements, stem versions, you're more or less okay. Whether there is any soft tissue tension, because you're shortening as well. So sometimes that can be an issue.
The shortening occurs in the, we are doing the subtrochanteric osteotomy.
Subtrochanteric, correct, yeah.
So essentially for the soft tissues around the hip, we are restoring actually good abductor tension, good soft tissue tension overall. So a chance of dislocation almost comes to a nil. Krishna, would you have anything to add to this?
The procedure itself is very complicated, so you can make many mistakes with respect to the cup inclination version, the way the subtrochanteric osteotomy is put back together. So there is potential to make a lot of errors. So in that sense, the instability risk is higher. And it is also a dysplastic type of scenario. Sometimes if it is a Shan's osteotomy, there is a distal varising osteotomy, as Professor Anil Arora mentioned, which can have a torsional component to it as well. And when we do surgery, we do a extensive soft tissue release, including iliopsoas and the adductors and all these are released. Except for the abductor, everything is removed. So the soft tissue support as such, although the soft tissue tension, when you do it well, is really good, and I would agree with you that we have not encountered any instability. If the surgery is done well, the scope for making mistakes is higher, and the chance for early instability in the absence of special implants, like you would probably know nowadays, the size of the socket would be 40, 42. Sometimes you just have a 22 millimeter head. And despite that, our own experience is that it doesn't dislocate. But the challenge here is early precautions probably are a good idea in these sort of cases for the first couple of months till the soft tissue scarring happens, because the patients really cannot control how they get out of bed, and then they sit on a toilet seat and then they're getting up. That is when it dislocates. And 75% of them, if otherwise everything is done well, they don't re-dislocate. So 3 out of 4, they keep doing well. So that's what is my take on it.
I think that's a very, very valid point, Dr. Ajit. I think especially Dr. Sanjeev and Dr. Anil has some questions to make, and Dr. Ronan can get his presentation ready. I think he's next on the line. So by that time, yes, Mohanty, you had something to say?
No, I just wanted Dr. Ajit to mention here that how to reduce a dislocated THR and how long you immobilize and what is the mode of immobilization, because for the benefit of the delegates.
Yeah, sure. Thank you. So, post-op immobilization for this guy, all we did was to give him a knee brace. So that was easy. And here, since there was it's not a metal cup, it is just a plastic cup and well seated, there was not too much of a problem. We just, under relaxation, gave in flexion, little bit of traction and gently abducted and internally rotated. That's all. It went in quite easily. It stayed there.
I think
Sanjeev, it reduces, then it is easily likely to dislocate. If it's little difficult to reduce, then probably that hip is going to be stable.
Yes.
Yeah.
Yes, Mohanty.
No, I had only one comment to make, which I did it.
Yes, Sanjeev?
Yeah, I had only one comment to make. I did that.
Okay, very good. Okay. Anil, Dr. Anil Arora, anything to say?
No, just he has already answered, post-op management.
Brilliant. And I think the take home would be, I think like Krishna pointed out, Najit pointed out, after a subtrochanteric osteotomy, I think it's better to be careful for the first few months, especially till the fracture unites and the soft tissues are allowed to heal. But otherwise, well done. I think that's a point well taken. Thank you. Over to Dr. Ronan.
Right. Can you guys see my screen?
Yes. Please go ahead, Dr. Ronan.
Right. Well, I've got a relatively simple case. This is a 73-year-old lady. She was immobile following a domestic fall about 6 months ago. And she was actually admitted at the time in a neurosurgical hospital in a drowsy condition, where she was diagnosed to have a bilateral subdural hematomas, which were decided to be treated conservatively. And she was also diagnosed to have Parkinson's disease at the time. So this was diagnosed 6 months ago and treatment was started. And while she was recovering, she had other medical issues, which were really her major problems. She had hypertension, dyslipidemia, type 2 diabetes, interstitial lung disease, chronic liver disease, urinary incontinence with recurrent UTIs, and a bifascicular heart block to add to all the chaos that was prevailing. And before discharge from the hospital after her conservative treatment, she wasn't able to walk and she was beginning to complain of pain in her left hip. And that's when the in-house orthopedic surgeon saw her and decided, in view of her multiple comorbidities and the fact that the neurosurgical team did not give the clearance to operate, she was decided to be treated conservatively at the time, and she was discharged home. And previous to that, bipolar had been done in November 2018. So that's about 5 years earlier. And she'd had an uncemented bipolar hemiarthroplasty, and she was well till her fall in March. And she had a subsequent fall again in September 2020, when she had a fracture of the left neck of humerus, which was treated with a Philos. And during that time, treatment of her osteoporosis was started with denosumab injections, calcium, and vitamin D. And she presented to us in end August 23, immobile since her last fall in March. That's about 6 months ago. Neurologically, she was much better. She was a very pleasant lady given her age and all her multiple medical issues. And the main problem was she was having difficulty in sitting due to the prominent bipolar head in her left gluteal region. And honestly, giving her colorful medical history, I really wasn't very keen on doing a surgery. But patients and relatives wanted a solution and were willing to accept any surgical and non-surgical risks, including death, on the table. So given that sort of scenario, I referred her to the internal medicine team, the gastro team, the pulmo team, cardiology team, the urology team, and the neurosurgical team. And that's the problem of working in a tertiary center. Everyone gave clearance with high risk. And the only other additional thing was that she was advised of preoperative pacing, and existing UTI was treated, and she was deemed fit for surgery. So these are her X-rays. And my question before you is, what do you think has happened, and how would you manage?
I think it's open to the house, I think.
Yes, I mean, anyone willing to take it on?
Is there a
The greater trochanter, it is the greater trochanter is not seen here.
Correct. The greater trochanter is not seen. Well picked up, Subhangshu. Anything else?
I think
Maybe the third X-ray, you can see it is flying away near the bipolar cup.
Correct.
And next, we have to see version of the stem also. That will be more apparent in a CT scan, but and the acetabulum looks little posterior lip of the acetabulum. Doubt whether there is a acetabulum looks little vertical to me.
Now, how many months since the dislocation, Ronin?
6 months, March. In fact, she presented just about 4 weeks ago.
Abductor dissociation is one issue we have to keep in mind.
Right. So I think you've picked up all the orthopedic issues, and well done, Shubhranshu. And basically, there's acetabular erosion, and along with that, the GT was avulsed. And you can spot the GT lying there just behind the head superiorly. And the CT scan actually confirmed that. The version was actually okay, though I don't have the transverse CT scans with me at the moment. Her blood was otherwise normal, complete blood count, ESR and CRP, and the urine showed no growth after treatment. So the question is, what are the plans? What's the options? What are the pros and cons? And this is a lady who you really want to do a minimum, because the anesthetists were not keen on any prolonged anesthetic. So should we try and reduce, convert to a THR? Is an ETO possible in this patient? Reduce and fix the GT, maintain the stem? What would you like to do?
I would convert to a totally replacement with dual mobility cup. Stem is version is good, then with that stem, can go ahead doing a dual mobility cup.
And also
fix the
at the
GT.
same time, fix the greater trochanter also.
Greater trochanter, yeah. Agree.
How would you fix the greater trochanter?
Well, yeah, Shubhanshu.
Yeah, I'll fix it with the ideally K-wire tension band wiring, but to have a better fixation, we can use a greater trochanter plate as well.
Right. Well, we decided that we'd maintain the stem because the three-phase bones can actually show that there was no evidence of loosening. And to do an ET on this lady would have been actually, there would be very little left of her bone. So we checked for the taper, made sure that we had the correct size taper available for the head. And we just did an exchange, and this is what we did. And we managed to retain the head, 44 millimeter cup, 28 millimeter head with a matching taper, cup slightly closed and antiverted to try and make sure that we got as much cover as possible. We reopposed the GT with 3 separate fiber wires, two number 2 fiber wires, and an adductor tenotomy was done because she had quite a strong adductor moment and the adductors were quite tight. We managed to get reasonable tension and appeared quite stable on the table, but given her neuromuscular disorders, we decided to play it safe. And at the moment, this is her in bed in the ICU. She's developed a post-operative UTI for which she's undergoing treatment. And this is pictures from 3 days earlier. So my question is, when would you like to mobilize her, and when would you think would be safe to mobilize her? I mean, the last thing that I want is for her to dislocate again.
This would have been better with a dual mobility to start with, because it was a multifactorial dislocation. So this is one indication for a dual mobility to start with. 28 millimeter head, with the GT deficiency, then now the risk of redislocation could be higher, especially considering her age and situation.
Was there any cup deficiency?
Sorry?
Dual mobility, of course, like Krishna says, is a mandatory thing. And
Yes.
then addressing the abductor deficiency, which is the biggest worry now. In addition, I think probably a glute max partial transfer would have been more appropriate to augment this. Fiber wires are not going to hold it, and it will take a long time for it to sort of fibrose itself. Give it adequate time. If you have to immobilize now in this position, at least about 6 weeks, 4 to 6 weeks.
That's what my plan was as well, 6 weeks.
But that's again not good for the chest and for this elderly lady after a long surgery.
Suri, just a quick, can I ask you, especially what it's a 6-month-old dislocation, right, Ronan?
Correct.
Yeah. So the challenges in bringing down this for Krishna also. Yes, your point well taken. It should have been a dual mobility. To bring down that big an greater trochanter chunk, would you think it would be, like the challenges for that?
Precisely, that's what I'm saying. You can't bring it down. You won't get approximation, osteopenic bone, fiber wire will be floating in the soft tissues. Augmentation is the way to go in these cases. There are 2 ways we could do the glute max, which is described. The second one is just bring down the whole composite fibrous mass down and then reattach with probably something like a Marlex mesh spacer. That's what I do into a couple of situations, because this Marlex mesh, which is the hernia repair go-to, induces intense amount of fibrosis. Yeah. So that fibrosis will be then the continuum between the muscle fibers proximally and the trochanteric area distally. And that healing which happens is more robust than just a primary fixation.
And how much time would that take?
Again, it takes about, in fact, the gentleman I showed walking, he had the similar one, 4 months dislocation. The healing probably will take again about 2 to 3 months. It's not going to be easier.
But actually, if you do that in combination with the dual mobility, that will take care.
Yes. I think we need to recruit all the possibilities to add up to this.
So Krishna, get ready for your presentation. Krishna is next while we take on the next few questions. Krishna gets ready.
Suri, I have a question.
Ronan, Ronan, what about the use of the constrained liner and allow this patient to be?
Well, unfortunately,
so I'll be showing the one case for the same.
we wanted to use a constraint liner, but unfortunately with the 44 cup, they didn't have a matching constraint liner. It started from 46. So that was the issue that we had on the table. In fact, that's what the original plan was.
With a fresh cup, constraint liner doesn't seem very.
Anil, can I make a comment, Anil?
Yes, please go ahead. Sorry, I can't.
Yeah, sorry, I'm on my hands-free. Just
No
one
problem.
comment about the constraint liner.
Go ahead.
Yes,
Nikhil.
Nikhil. Yes.
Nikhil, go ahead. No problem. We can hear you.
He's on the road.
Yeah, so
Yes,
the
Nikhil.
forces are very low. When you put a constraint liner, can you hear me?
Yes.
Yes.
Yes. Go ahead. Loud and clear. We seem to be losing you in between.
So when you put a constraint liner, and if you put in yeah, sorry, I'm on my hands-free. That's why. It's okay. I'll try and park later on and make my comment at the end. You go ahead.
I have a question to Suri. Where do you put this mesh? You put it in the gap in the bone or in the muscle?
In between the soft tissues, whatever tissues are there, you just take it along and then wrap it around. You fold it 3 to 4 times, so it becomes like a cord, and then you just dig it, repair it proximally, repair it distally.
It to the bone.
And into the soft tissue itself also is fine. If you have some bone to fix it, fantastic.
Okay.
See, if suppose you got the distal stump of the tissue attached to the, in this case, you won't have it. So just take some transosseous sutures, fix it up, rotate all the tissues and suture it out.
Okay.
I mean, this is a cheap, straightforward, simple.
Yeah, I think we can try it next time.
We'll discuss. We'll take. Yes.
I'll report in 6 weeks.
Sure.
Definitely. Okay, Doctor. Okay, so Dr. Krishna, and up next is Dr. Rajiv, followed by Arun Kanen. Yes, Krishna, go ahead.
Can you see my slide?
Yes.
Yeah, so this is the case of unusual hip dislocation. I think we can take it slowly because just a single case. So this was a 39-year-old lady, and she was a Caucasian lady, and she had this problem on the left hip, mild pain, and probably a grade 1 dysplasia or something like that. And she went and got a hip replacement done for this particular problem. And somebody did a direct anterior approach hip, and post-surgery, there was a 3 centimeter lengthening of the leg, and the leg was entirely abducted. And she was unhappy with the hip, and it got it revised 2 years later and developed habitual hip dislocation. So this is what was done. This is the revision. So this is the stage with which she presented to me, and she didn't have previous x-rays. So she had undergone an isolated cup revision, and the leg for her appeared to be longer, and she had this sort of a situation. Every time she had to lie down or sit, she had to dislocate her hip, and then every morning she would relocate it and walk on it. And this is the situation with which she presented to us. She had a fixed adduction deformity of the lower extremity, about 30-35 degrees, and about 1 or 2 centimeters of lengthening of the left leg, and she was very unhappy, and ESR CRP was normal. So I think anybody can take this up. What would
yes, Krishna? Okay, any takers? So you said the primary hip was done, and then she went on to.
Was not indicated. The hip was not indicated.
Correct.
It was the
correct.
X-ray.
And she was, and the revision was for the lengthening.
Correct. So the patient had lengthening and always had to walk with the hip abducted. And what happened was somebody in the interim, we did an abductor release for her.
Abductor release?
Abductor release, because there was abduction contracture of the hip. And then she started...
Where did they do that release? At the crest or?
At request, because the hip was abducted, she was unhappy. Patient...
No, was it at the IOA crest?
She was also a little bit abnormal. She'd come from some other place. She was very highly anxious, strung, and different. So she underwent that abductor release and then started dislocating, and somebody revised it. And then she developed an adduction contracture and recurrent habitual dislocation. That means every time she sat down and had to sleep, she had to dislocate her hip. And in the morning, her sister would help her to relocate the hip so that she could walk around. And she walked with that leg being completely adducted.
So question is,
So,
Krishna,
this
that means the abductors are compromised, right? In this,
Yeah, you can see the
yes, the GT area is correct.
little bit, yeah, bald and
Krishna, one question.
Yes, sir.
This patient seems to be having a significant adduction contraction.
Yes, sir, that is
Yeah.
true. Yeah.
So that seems to be the one of the reason why this patient is having dislocation.
Yeah, that is true. And if we also look at the preoperative, the X-ray on the opposite side, and look at the relationship between the center of the femoral head and the tip of the trochanter.
Yeah,
it
the
seems
vertical
to be,
offset is very high.
Yeah, significantly valgus and over lengthened on the femoral side. And if you look at the cup inclination, whatever is the cage that was put in, this seems to be a little bit more vertical than what would be accepted.
Yeah.
Right.
So, but the issue there.
So there is
The
a
issue there
vertical
is
offset.
basically.
Yeah.
Increase
Go ahead. No
offset,
problem.
and there is a short horizontal offset and with a vertical cup. The cage might be put in position, whatever position, but at least the liner or whatever has been put inside, that should have been given adequate inclination and diversion. It looks vertical. So
Mohanty, we won't be able to comment on the liner, correct? We won't be able to comment on the poly position, right?
Mohanty? This is a Lima trabecular metal cage.
Okay.
That is not available in India, but it is a triple modular type of device. You have a cage ring with a metal shell which gets locked into it with a bolt, and then you have a polyethylene liner which has got a 20-degree phase changing. So you can change the version inclination with the polyethylene. So it's a three-set process. One TM-coated cage, then you have a metallic ring inside, and this thing, the polyliner, which has got 0, 10, 20 degrees of version options where you can change the version based on whatever is the requirement. The head was a 32 millimeter head, and we saw the bio ball by Dr. Nikhil a little while earlier. So this is the implant which is manufactured by the same company, Lima.
So Krishna, this seems to be having all the elements for this adduction contracture, the soft tissue laxity, and also the wrong inclination of the cup. So what have you done for this?
Yeah, so this is a case where your etiology of instability is multifactorial. You have acetabular cup malposition, it's a type 1 problem. You have a femoral issue, which is a type 2 problem. You have abductor insufficiency, which is a type 4 problem. And probably some unknown etiology as well with respect to the thing. And this is what is the situation. So she had this completely adducted limb with some pelvic obliquity and then the equinus at the ankle. But if you look at the leg length measurement, then the leg length measurement was not too far off. And whenever she lay down, she had to dislocate the hip. You can see it's adducted, flexed, and internally rotated. So this was a challenging case for us, and we decided to do a both component revision. And when we exposed the hip, initially we retained the stem, and then this is the cup inclination. You can see is around 56 degrees, and the effective version was around 4 degrees of antiversion using this mobile based device. The inclination is more accurate than version. Version sometimes depends upon how the pelvis is flexed or extended. You cannot be 100% sure. So we got the polyethylene liner and the things out, but we were not able to remove this shell because it is TM coated and it was fully ingrown. So the position of the shell was around 60 degrees of inclination. So we needed to do something. So what we decided to do was we wanted to do a dual mobility cemented cup. And since this shell was not a sort of a trabecular metal coated on the inside. I used a TM augment to close that cup down and have some fixation for the dual mobility cup as well. And then we fixed that augment to the cage with 2 screws and cemented a dual mobility liner in around 33 degrees of intraoperative inclination and then 20 degrees of antiversion. And then we changed the stem as well. So we did a limited slot femoral osteotomy. So we just split open the linea aspera, putting a prophylactic wire just below the where the coating ends. So and then we can safely remove the stem without having to do an extended trochanteric osteotomy. And we changed the neck shaft angle and also the length to more anatomic as for that particular patient. And this was the combined antiversion. So we used around 8 degrees of version on the femur and got a 28 degrees of combined antiversion and used a dual mobility shell with a ceramic on highly cross-linked polyethylene liner. And that's the immediate post-operative X-ray. You can see that we have restored the relationship of the center of the femoral head to the tip of the trochanter. And also the length of that leg has been restored. And this is a follow-up at 10 months where everything has healed up. But the patient still is not happy with her surgery. She says that she read too much up on the internet and she says, I need some shortening of the femur, this, that. But currently the hip is located and she's able to manage. So that is the case. And I just brought out this algorithm as a take home that if you have a primary THR and it's a first dislocation, you must do a close reduction. And that was shown by Dr. Ajit. And then you do bracing and it is successful in 3 out of 4 cases, that is 75%. And if it is unsuccessful, you must rule out infection and find the cause. It could be component malposition, in which case you do a appropriate procedure in the form of bioball and liner exchange as was shown, or a full component revision. You could have soft tissue laxity, which can be will lead to impingement, and a combination of soft tissue laxity with abductor insufficiency, which can be managed by using increased neck length, lateralized liners, larger head sizes, and sometimes the etiology is multifactorial, unknown, or this sort of a situation where it is habitual, where you are trending more towards a constrained liner or a dual mobility cup more often nowadays. And sometimes a girdle stone may be the only choice we have in patients who are unhappy with their surgery or we are not able to solve the problem. Thank you.
Thanks, Krishna, for that very challenging case. Just a quick comment, Rajiv. Can you would you get ready for the presentation, Dr. Rajiv, while we take a couple of questions? I think, Krishna, just a quick question. You said the trabecular metal cage itself did not, yield because it was not budging from that place. One question is basically what was the size of the cage? Do you have a? I mean, did you read off that, or what is the size of the cup that you took out?
It was a 54 TM cage.
Okay, so my question is,
I'm not a great fan of these custom-made implants and these cages for the same reason that
sure,
if you are having to do some sort of a revision procedure on them, then it is a big nightmare if it gets infected or,
No, but I mean, I like the way that you put in the trabecular metal augment, because that was trabecular metal on, so you don't have an issue with metal on metal or two different metal combination, because both are trabecular metal based, right?
That is true. But since it is all unitized with cement,
there shouldn't be a problem.
I'm not again a fan of standalone metal-backed cemented cups, because the literature has shown that these have got very poor outcomes. So if you just put in a blob of cement with a metal-backed, all cemented metal-backed cup, they don't really do well. So you must use a combination of a cage with some sort of a trabecular metal augmentation whenever we are using these devices, because it's a young patient and there is no other option for this patient. So the other option would have been to cement a constrained liner into this cage and the TM construct, which we considered, but we were able to get away with a dual mobility, having looked at how the constrained liners will have.
I think that would have been the first choice.
Yeah.
Correct.
So what you
Thanks,
did,
Krishna. Over to Dr. Rajiv. Please reserve your questions for the end. I think Party has a question. We'll take questions later. Over to Dr. Rajiv. Rajiv, you're muted. Can you unmute yourself? Dr. Rajiv? Dr. Rajiv, you're muted.
Can you hear me?
Yeah, now yes. Now yes. Please go ahead.
Thank you, Anil. Wonderful cases for very difficult situations. I'll show two types of situations where the constraint liners are and where the dislocation of the constraint liner itself is managed. Now, this patient, who's an 80-year-old male, fell on the floor and fractured his left trochanter. And for this, we did the bipolar hip arthroplasty. That is the 2 weeks post-operative X-ray and the pictures. And this patient was doing well. And then after, this patient had a fall, and which was reduced. And then after, patient had a again fall. So there were 3 occurrences of that dislocation and reduction of this patient. And we can see here which that trochanter is not very well placed now because of the recurrent dislocations. So broken in this due course of time. So would somebody like to take on that? What will be the advice at this stage? Anil, or do I just go on?
Yeah, I think Dr. Rajiv, you just go on. I think we will comment at the end. I think for want of time.
So
I think we have a good discussion at the end. Sure.
Yeah, thanks so much. This patient was old, and we wanted to ensure that the patient is on his feet at the earliest possible time. So we chose the cemented constraint liner and fixed the trochanter again in this patient. But that was not the end of the story. What we see is that patient had a fall again, and he had a fracture of the trochanter on the other side. Now, this side, we did not wait for any time, and we went ahead and did the constraint liner on the other side itself in the same stage. So because this patient was having the recurrent fall, which may be because of many reasons, the support at home, the debility because of his age. So we ensured that this patient is able to well, and that's what the patient's follow-up. We can see, and this patient was, in fact, he survived for about 5 years post-operative, and last COVID wave, we could not save him. The other case that I'll show the another very interesting situation of the constraint liner. This patient where we did the total femur replacement, and with the total femur replacement, we used the constraint liner. That's what we have this patient. That's the 2 weeks post-operative, and that's the 5 years post-operative, where the patient was doing very well. He was able to walk without any support, and with a mild amount of limp, which was expected. But these patients the story doesn't end with these patients at this stage, because you see that at 5 years and 3 months, patient had a fall and he dislocated his hip. Now, may I ask our friends here that what could be the reason of a dislocation, and what do you see the reason for the dislocation of a constraint liner in this case? The reason was the liner ring was broken and significant was there, and these two were the reasons for the failure of the constraint liner, because these patients are very high demand patients because of their age, and because when they do a surgery like this, they are able to go on in a very good way. That's what we saw, the broken ring, and that's what this ring was changed, and again the same liner was used. The same constraint liner was used, and that's what the patient's function 6 months post-operative, the second surgery. Anil, I don't think I'll show more case.
No, I think that's a very good display. Just a quick question, Rajiv. I think Arun is next in line. Arun can get his presentations ready. I think there will be a lot of questions. So, Dr. Suri, I'd like to ask you a comment. Dr. Rajiv, can you go to the pre-op X-ray for your first case, please? The trochanteric fracture, Dr. Suri. Yeah. The first one. Yeah. So this situation. Now, how are we for, 80-year-old male fall on fair trochanteric fracture? What would be your go-to? Is it a bipolar, uncemented bipolar type with fixing the fragments if we go to a THR, or do we go for a fixation? What is our take on?
My choice in this case is usually uncemented but bipolar and a good proximal reconstruction. The second important point one can probably talk about is how you approach this. It is, rather than take a composite both of the abductor along with whatever the bone is attached to the abductor along the quads, and then reflect it so that in the abductor composite mass of the vastus, trochanter, and the gluteus remains as a single sleeve. So when you put the thing in appropriate length and you pull it down, the tissue works as a unitized assembly. And then, of course, you will reattach whatever is required. That if you cut transversely and get into the joint, or if you go through the fracture, probably, I think we would end up probably devitalizing the tissues much more. So this is what Vijay and myself, we always do, that we take this, the primary thing is to take out. Second, to avoid any dislocation is do not take out the labrum.
Do not take off the labrum.
Yes.
So I think that's a very important message all around. One is, I think, respect the labrum if you're doing a bipolar. Leave the labrum, and I think reconstitution and reconstruction of the abductor mechanism, that is the GT and the LT unit composite with the IT band, is very important. Isn't it, Dr. Suri?
Yeah, absolutely. Absolutely.
Suri, you said that cementless stem or a cemented stem?
We use mostly a cementless. And of course, if it is a type 3, DOR C or something, probably one can certainly do.
Right.
But the cementless, cemented, sometimes if the crack and the displacement is more distal, then it becomes a slightly compromised. And it's a matter of time also in these cases, you are in and out as fast as you can. So a 190.
So you are mentioning because of the cement spilling, the trochanteric union may be an issue.
No. More importantly, even your fixation, your lesser trochanter is totally broken down. So you're going to have a diaphyseal fixation, which is not adequate. And a 190 Wagner to get a fixation drive down doesn't take much time.
I think the additional advantage of the Wagner is that also it has an inherently larger horizontal offset.
Yeah.
Which gives it a better
additional stability.
That gives a better stability.
Yeah.
Yes. So I think the message here is
intratrochanteric fractures, you can use a Wagner stem 190, or else I use a cemented stem of CPT or a Exeter stem, which is 150 millimeter.
With high offset. Even a cemented but high offset stem.
Two important things, that the version and the vertical offset. They are the two things one should restore. It is difficult since Kalkar
vertical and horizontal. Correct.
Yeah, version and the length is important.
Anil, can I ask a question here? That will any of our RLT prefer the fixation in the age and fraction?
Okay, we can have a show of Ajit is smiling. I don't know. Ajit, whether for the right side.
Because Rajiv, I think it is very important. Yeah.
Krishna?
Yes, Rakesh. Yeah.
Krishna, arthroplasty.
For me, always.
Very happy fixation.
Krishna, Rakesh.
Fixation for me.
Yeah.
Fixation for me too. This is easy.
Nikhil is online. Nikhil, what is your take? If Nikhil can hear us, or
we fix these fractures. We don't do primary total hip for intertrochanteric or subtrochanteric fractures.
Yeah, Sanjeev.
Okay, Sanjeev is put his hand up again. Sanjeev.
Yeah. So basically, previously I used to do a lot of total hip or the bipolar, whatever the Dr. Suri is advising. Since the time these new AOPFN and other stuff has come up, I think I practically fixed all the fracture and have a good result.
I think it's a very tall claim.
Rakesh?
Yeah,
Sorry,
I just
Dr.
mentioned
Suri,
that,
after
you
that.
know. So there are criteria when you would primarily go for an arthroplasty, but that's only a very few exceptional circumstances. The go-to treatment will be fixation. Of course, there are varieties which just Sanjeev mentioned. That's a TFNA has been come out, very good one where you can even put cement actually through the leakage. This gives you wonderful, and you can mobilize. It's not like you can only mobilize with arthroplasty. You can mobilize after fixation also.
Yeah, that's
Okay,
a big
interesting.
issue.
Dr. Suri is saying something. Dr. Suri?
I think
Yes,
the
sir.
indications when to go either way is very well defined today. And it is not that the nail is a be all end all. It is not the bipolar be all end all. But I think there are other factors also that come into play. The whole basic patient profile at that point in time and the morbidity and the other associated factors. We need to put all this together and fundamentally something which can get them up and out as early as possible with no concern. I think we need to go.
Right, well taken.
The results are comparable both ways.
Case by case, whatever it is, respect soft tissue anatomy and go ahead. Thank you very much.
Right, but one thing remains in cases that the mobility is definitely better with the bipolar cemented or cementless. And this patient had a dislocation, but as we all know, especially for the younger colleagues who are there in the webinar, that several other bipolar that are done, they never have a dislocation so much. So it doesn't mean by seeing this case that all bipolars will have a dislocation.
Yes. Over to you, Dr. Arun. Arun, are you ready with your presentation?
Yes.
So Anil, by the time Arun comes, I'll just put in a point. If you
Yes,
look at,
please.
if
Yes,
you look at the
Rakesh.
published literature, the initial mortality with bipolars is much higher than initial fixation. So if you have a choice, fixation takes over.
Yes, I think Rakesh, you were referring to that meta that came out recently, I think, correct?
Yeah. There's a recent one and also one from the Parker series, from the Cochrane review.
Yes. Yeah, I think.
Yeah, that's a big question which will remain.
Yes, I think this debate will always go on. Anyway, we'll continue the discussion at the end of this. Okay, go on, Arun. Over to you.
Yeah, yes, sir.
Arun, yeah.
64-year-old female had a simple femoral neck fracture. So she initially had this uncemented non-modular bipolar done elsewhere. And then within 2 weeks, you've seen that the stem has subsided and she dislocated. And then, so the initial surgeon converted into a cemented hemi to avoid the subsidence. And I think the point to note here is that the offset has not been restored. It looks like a very short offset for this lady. And then she again dislocated 5 days after the revision surgery. So this is, she was like this for a few weeks and then presented to us. 4 weeks after the second dislocation, hip was unreduced, wound was okay, and CRP was normal. And I'll go on and finish the case, sir.
Yes, please, Dr. Yes, go ahead.
Operatively, the stem was in about 15 degrees version. It was well fixed. There was no problem on the acetabular side. The stem was removed. The cement mantle was healthy. So what I chose was whether to do a bipolar or a dual mobility or a primary regular hip. The bipolar outer shell was 41. That roughly translates into a cup size of approximately 46 mm, and that would have a dual mobility head outer articulation of about 38 mm. The question that came to my mind at that point was which would be more stable, whether a 41 mm bipolar or a 38 mm dual mobility. But we did go ahead with the dual mobility hip. For the stem side, it was a non-modular stem, so I wanted to revise it to better restore the offset. So instead of doing an uncemented revision that would require an ETO to take out all the cement, we did a cement in cement revision. It was a fairly recently cemented stem, so cement mantle was good. I did a cement in cement revision and a dual mobility socket for this lady, and she continues to do well. It's post-op, and this was 3 months post-op. And she's been stable since. The question was dual mobilities have come up as a good answer for unstable hemis, and that is because they have a hemispherical shell as compared to an anatomical socket, which is subhemispherical. So even though the bipolar articulation is slightly bigger than the dual mobility bearing, a dual mobility seems to be more stable than a bipolar. So that is the first thing I wanted to. So a restoration of offset, dual mobility, good option for an unstable hemi, and cement and cement revision, especially for instability, simplifies the stem side part of the revision. Second one is a 24-year-old female. She had a spinal neurofibroma tumor excised at 2 years of age, and she came with right hip pain. She had significant weakness on the right lower limb, hips, knees, as well as at the ankle. Of note, she had 3/5 hip abduction. The hip extension was even weaker. And this was the picture, 24-year-old. You can see that in adduction, she's already coming out preoperatively. So we planned for her with the robotic system. So we've been using the Mako robotics for doing hips. And this is how we planned. We got the spinal x-rays done. We've taken those values into consideration here. So normally we plan for a 40 cup inclination, 20 version. And the native version was 16, and we initially planned for the same. And with the adjustments, you can see that as compared to the opposite hip, we have restored the length and offset is 2 mm increase as compared to the opposite side. So now with the Mako system, we can put her through a virtual range of movement. So with 90 degrees flexion and 55 degrees internal rotation, she was having an extra-articular impingement, what Dr. Suri sir was referring to. The GT was going and hitting against the AIIS. So this is where we were looking for options to correct this. So in this scenario, this is what was happening, the GT going and hitting against the AIIS. So just to illustrate, if you change the cup version, taking into account the combined anti-version, it doesn't change the impingement here. So changing cup version will not correct this extra-articular impingement, cup version. So here offset has been already restored, but in the interest of stability, what we did was increase the offset and length. We put in a +8 head as compared to a 0 head, and this made the hip 6 mm 4 mm longer and 6 mm increased offset, but you can still see this red shadow showing that she is still impinging. So this is where the options were explored. So maybe can I have this one, anybody can take a call on what next to do. This is all in the pre-planning stage.
No, go ahead, Arun, and then we will discuss.
So we increased the stem version to 25 degrees from 16 degrees, even though the initial combined anti-version was good. And this took care of the external impingement. So what we could conclude from this case was, this was a post-op X-ray. So the stem version accounts for external impingement also, while the cup version does not have anything to do with extra-articular impingement. That is one thing that we could see from the CT planning based on the robotic technology. So this was the immediate post-op, and this was 3 months post-op. We've lengthened her a little bit and increased the offset also, but it was the stem version. To gain extra version, we've used the Wagner stem, conical stem, to increase the version, so that it would go well beyond the native version. So for extra-articular bone-on-bone impingement, the corrective measures are increasing the offset and femoral version. It is not affected by the acetabular version. So therefore, we cannot use combined anti-version alone to give protection against extra-articular bone-on-bone impingement. Femoral version holds the key here. Yeah, I think, thank you.
Thanks, Arun. Both interesting cases. We'll get some questions. I think we'll answer the chat boxes first. Yes, Dr. Rajiv.
Anil, one thing,
yes.
That the dual mobility is a very useful device, and recently just a comment that one of the constraint liner we had to revise to a dual mobility, and it has been doing very well. Second, Anil, this patient was having the impingement at 55 degrees of abduction, right?
No,
Yes,
sir. It was
rotation.
90
No,
degrees flexion and 55 degrees internal rotation, neutral abduction adduction. This is like a combined
Right.
scenario where the patient sits. So for the planning purposes, 90 and around 55, 60 degrees flexion you would like to have without impingement so that they are
Right.
safe.
I think, Arun, that's an excellent presentation of that case because I think this
Very
is
nice.
exploiting robot to the full, you know. The virtual position, virtual impingement which we are seeing and which it's very difficult to do. I think if you can have that detail even before you start, I think this is a great tool. Very well executed, I think. Like he clearly mentions, there is always a boundary how much you can do on the socket, how much you can do on the femoral side. When we talk about dual or a constraint, probably you're only adding the system constraints, but that's not a solution.
Right.
Primary situation. As much as possible.
Especially Dr. Suri, especially when you can see it virtually before you've actually fixed the
absolutely.
Yeah, I agree. Yeah.
So, Dr. Suri, can I quickly ask you, if that is the case, you said there is an upper limit. Yes, the established version also there is an upper limit. Even on the femoral side, he anteverted to 25 degrees.
Agreed.
Agreed. So now when we do not have the robot and you're trying to replicate it, say with a trial implant in situ.
In all this, I think we should have a trial of the socket and a trial of the stem and then play around and then do a practically eyeball sort of a situation and then fix it. Now what happens, we finish and for the cup. And then when you come down to the stem.
Yes, exactly. So does it come back to the same dictum that when we are in doubt, do the femur first?
Yes. Yeah, I think some people do it routinely, but the other way also is true. Correct. I agree with you.
Okay.
Nikhil's phone was coming in.
Okay.
Any comment, Nikhil?
Yeah, Nikhil, are you there?
Yes. So we have the robot, but I have to say I'm not very impressed with the robot. We have just revised 3 robotic assisted total hip replacements for dislocation. But that problem where you get the extra-articular impingement, I mean, personally, for someone who does hips for a living, I don't think you need the robot, because what all you do is when you're doing a hip finger in deep flexion, internal rotation and adduction, and then what I tend to do is you take the trial stem out, you take a Lambotti osteotome, and you take it along the anterior neck and the anterior trochanter, and you basically do what I refer to as a reduction plasty of the anterior trochanter, including the osteophyte. And you can almost every case that will sort out your extra-articular impingement. The problem with offset is you can offset it to a certain degree, but women particularly, they don't like over offsetted hips. They really moan and they're really in pain.
Yeah.
There was one comment I wanted to make about the constrained cup, particularly that neuromuscular case. So what we have observed is that in neuromuscular patients, the forces are so strong that if you don't allow the hip to dislocate in a constrained bearing inside an uncemented cup, particularly in older people, basically the next attempted dislocation will rip the cup out of the pelvis. And that is a hugely difficult problem to solve because you get some irregular fracturing of the acetabulum, you sometimes get discontinuity. So when I do my discontinuity cases, or if I'm doing a custom case, I never use a custom line. I tell them that you might dislocate a few times and I don't mind that. But once the cup is fully ingrown or once I've got good fixation, if needed, I'll go back in and change it to a dual mobility liner, or I'll use a primary dual mobility liner nowadays. But we have seen a lot of problems with the constrained bearings.
Nikhil, you made some great points here. Can I add, Anil? You have a comment?
Yes. Please go ahead. Yes, please go ahead.
I think it's also that sometimes when you have this technology in front of you, we tend to get distracted. We think that the whole thing can be solved by this, like Nikhil said. Yes, of course, you can work on reducing the anterior flare of the trochanter and the soft tissues, and then increase it by another 5 to 10 degrees to the satisfactory point. That is one. But then I think we can't take away the the benefits and some things which we were probably just eyeballing all the time, that we have actually a red spot starts flashing red, and you know that that is an issue and you want to work on it. I think we have to take both sides and then work it.
Agreed perfectly, Dr.
Dr.
Suri.
Suri, what you suggested, the technology, I agree that the technology has to be learned well and then followed accurately.
Yes.
So it's not necessarily that the robotic or earlier time.
What I'm saying is, what I was trying to say was, robot is not needed to size the socket. A robot is not needed to size the stem and where to put. That we all know. But what was probably eluding us, and then we had these strange sudden dislocations, was this type of impingements was pulling it out. And today we have a tool which is, red flagging all these certain things, especially in unusual situations, deformed morphologies, spinopelvic issues which are there. I think all these come into play at this time.
So, Dr. Suri, does the robot
if we can,
also
we can ask Dr. Nikhil.
Yes, Nikhil.
If you can ask Dr. Nikhil.
Does the robot also tell you about soft tissue impingement extra-articular, or only bone to bone?
Predominantly, it comes to bone to bone.
Yeah, so I'm sure you have noticed this, that when you do lots of revisions,
you
do get ectopic bone and bone to bone, but more commonly you get this dense adherent anterior scar tissue.
Yes.
Which is present between the anterior neck and the AIIS.
Yes, that's why I said all this.
The robot doesn't tell you that. So what I like to do is, I take some local anesthetic infiltration with adrenaline. I infiltrate that entire area to reduce the oozing post-operatively, and I basically, excise that tissue using a diathermy, and then, like I said, take a Lambotti and then get rid of the bony impingement. I mean, one case I've even excised the anterior inferior iliac spine and the reflected head of the rectus, and it did not lead to any functional problem.
I agree.
Anil, can I ask Dr. Nikhil, because he touched
Go
upon
ahead.
a very interesting subject.
Yes.
Nikhil, you mentioned just now that 3 of the robotic hips you revised. So could you please let us know that what were the reasons in these cases?
Trusting the robot too much and keeping your own judgment at home. That was the main reason. I think you have to be fully aware that
political statement.
That's a very important message, I think. Yeah.
No, I think Krishna and everyone is smiling. I think, see, we have come back to the old dictum of computer navigation. Garbage in is garbage out. So I think we have to use it in combination. I think Dr. Suri will also agree. I think it's use it in combination with
technology. We should not discount technology, but we should not put knowledge ahead of wisdom. So whatever we have over so many years is still supersedes the robot or computer or whatever we are using. But at the same time, you cannot trivialize the information. Certain situations, as Faisal said, spinopelvic and I think 5% of the hips really benefit from robotics. 95% of them don't require all that things. But if you don't use it in the 95%, you'll not be able to do the 5% well. So that's the catch with technology.
Anil, can I quickly present the case?
Subhranshu, yes, okay. You have a few minutes before we go on to our, I think the panelists are waiting for the rest of the discussion. And I think we should look at our chat box also.
We're already 9:15.
It's 9:15. So we have 15 more minutes.
Sign off, it's okay?
Pardon?
I need to sign off at this time.
Okay, sir. Thank you so much for your contribution, Dr. Suri. Thank you very much.
Thank you so much, Dr. Suri.
Thank you for joining, and thank you very much. Thank you for your wisdom. Thank you so much.
Same here, Anil. Sorry, I've reached the school, so I'll need to sign off. But
okay, Nikhil. Okay, we have. Thank you, Dr. Suri. Thank you, Dr. Nikhil, and we will continue with the discussion. I think it's only 10 minutes more, right, Rajiv? So we'll have Dr.
I think so. We close in 10 minutes for sure.
Yes. Yeah. So Subhranshu, yours time is 5 minutes, and then we have 5 minutes for discussion. Thank you so much.
Okay. So this is 72 years old female homemaker with a little high BMI 29, no comorbidities. A right cemented bipolar hemiarthroplasty done 15 years back, and left bipolar after 6 months of the right one. So both are almost 15 years. The revision of the right total hip was done outside in August 2020. That means almost 15 years after the bipolar arthroplasty. But unfortunately, this total hip dislocated 2 weeks after the revision surgery and presented 4 months later, and at times she was non-ambulatory. Those are the X-rays. So the concerns here, what is the type of dislocation, what is the cause of dislocation, and there are 2 scars of previous surgery. There is greater trochanteric non-union, and what to do, close reduction, open reduction, revision. Any take on this?
I think Dr. Subhranshu, go ahead and complete. We will discuss at the end because we'll give room for all the discussion.
Okay. So since it is a different type of case, it would have been better if you would have permitted some discussion. But,
no problem. We can. If we can, okay, we can give 2 rooms for discussion. No problem. We can give 2 questions. Not an issue. We have some time.
Yeah,
Yes,
just asking.
yes. No problem.
What is to be? One of you at least can take this.
Okay. First of all, the greater trochanter looks definitely lost its continuity. What about the version of the cup? Because at least in this view, the cup version looks to be in question.
Yeah. And
the cup version, because it looks a little open in this view.
Even the stem looks rotated.
Yeah.
The stem, I'm not sure the stem version or where it's placed. Any other comments?
Yeah. How to approach this? So do you do a close reduction or?
No, you said this is a first dislocation, right?
Yeah.
Okay. So now but it looks like it's compounded with problems. The GT definitely looks, we don't know the integrity of the GT. Close reduction definitely, but I think it'll be worthwhile looking at the version of the components before going in for, because this has to be close reduction for now, but definite management would be required with full assessment.
Right. Okay. So we'll go ahead.
Monty, did you get a CT scan done for this patient?
Yeah.
CT?
So ideally, CT scan should be done to know the version of the components. So we tried a close reduction, but we failed. And joint aspiration was sterile, ESR 56, CRP 6.5. So planned for a revision surgery. So these are the AP and lateral X-rays of the hip with the femur, just to look for the X-ray pictures. And we did a CT angio because, the head of the femur or head of the prosthesis was palpable in the groin. So it was like an anterior dislocation. So we did a CT angio. There are no vascular impingement by the screws. As you can see, the screw is going in. And we did a CT scan and it showed there's an excessive antiverted curve. So almost around 60 degrees of version of the, anti-version of the curve. So this was an anterior dislocation compared to the routine, whatever we see is a posterior dislocation. So the planning was for this case that we kept a wear removal set because you have to take out those wears. You have to have an explant system because you wanted to revise the cup. The position of the cup is too much antiverted. Moreland and Innovate system, in case the femur requires revision. We kept a multi-hole cup, constant liner, Wagner solution stem, long cemented and modular stems, allografts also, and spacious standby in case there is an infection. So at greater trochanter was not united. So we approached through the greater trochanter. So that is the acetabulum there. And what we couldn't see was there was a constant liner there, but the X-ray doesn't show anything. And there was excessive antiversion of the cup. That was the line, and that is the inclination and antiversion. Inclination was almost 50-60 degree, and the version was almost 60 degree antiversion of the cup. And the removal of this constant liner was very difficult. The ring came out, but to take out this liner, which is really a hell of a job. Though they have some instruments, but those are not useful. So we have to take out this liner really in piecemeal fashion this constraint liner. Then extraction of the stem was difficult and it was buttonholing to the muscle, but it was very well fixed cemented stem and the version was also quite okay, maybe little more anti-version, but it looks adequate to me. So I didn't revise the stem and used the explant system to take out the cup. This is after taking out the cup and put a multi-hole cup, standard cup, and that was the final cup position. Used a elevated liner, and the stability was quite good with this primary system. This is a flexion, abduction, external rotation, and then flexion, adduction, internal rotation, almost 60 to 70 degree internal rotation, it was dislocating. So that was the final implant inside, and greater trochanter we wired it and grafted it also. So that is the post-operative X-ray for this patient, and that is the post-operative CT scan just to see the positioning. There was almost 14.7 degree version, and inclination was 27, almost nearly 30 degree of inclination. So that is a follow-up of 1 year. There is no further dislocation, and patient is walking with the help of a stick there. Just 1 or 2 literatures. Anterior dislocation is a rare phenomenon after the total hip replacement. It is due to malpositioning of the cup and is associated with approximately 10 degree of excessive femoral and acetabular anteversion respectively. Immobilization of the hip, if you are able to do a close reduction, immobilize in 45 degree of flexion, 10 to 20 degree of abduction and neutral rotation, what is known as deck chair position. Comparison of anterior and posterior dislocation after a posterior approach, there was a 1:4.6 incidence of posterior to anterior to posterior dislocation. So posterior dislocation is almost 5 times more than the anterior dislocation through a posterior approach. This patient had undergone a posterior approach. There was a strong association between anterior dislocation and anteversion of the acetabular cup and femoral stem, size of the femoral head, and soft tissue tension. The higher incidence of post-operative posterior dislocation was found to be related to a soft tissue tension, revision arthroplasty, and incorrect posture. Thank you for a patient hearing. And this is one more literature, late anterior dislocation due to posterior pelvic tilt in a total hip arthroplasty. Of course, here the pelvic acetabular parameters come into picture, and because of the kyphosis of the spine, degenerative spine, there was a late anterior dislocation in this hip when the patient develops degenerative changes in the spine. Thank you for a patient hearing, and those who are the members of IOA there, I request and appeal that kindly support in my endeavor with the Vice President of IOA. The elections will be held from 22nd November onwards. Thank you.
Thank you, Dr.
Shubhranshu.
Thank
Anil,
you.
we have just 6 minutes maximum.
Yeah, so I think we can count down 6 minutes and we can take all interesting questions to the panel and question. I think we got to answer the questions in the chat. Somebody had asked for a cement in cement revision, and they wanted to know, while using a cement in cement revision, stem should be downsized. Yes, I think anybody, Dr. Rajiv or Rakesh, you want to take on that?
I can take that, Anil.
Yes, Rakesh, go ahead.
Yeah, so there are 2 things you need to understand here. One is cement in cement revision, and one is in cement technique. So in cement technique, you basically knock out the stem and you put a new stem, but the same company and same size. And in cement revision, you're going to put in more cement, but you downsize one size. But you got to be sure that that one size downsize is available before you start doing this technique. And generally, if like you're doing striker stem or something, your AP stem is always available to downsize.
The typical
Does it matter?
Are available in the ES system, exeter system for cement and cement.
Yeah, okay, Krishna, just a quick question. When you're doing a cement and cement revision, suppose when you're taking out the stem, the primary stem you're intending to revise, what would be your criteria for observing, say, the cement mantle, cracks in the cement mantle, deficiencies in the mantle that you would accept for a cement and cement revision?
The cement bone interface must not have any lucencies. So if there are any lucencies, then you must revise it. Second is the what is the type of cemented stem they have used. Sometimes I have found that it could be a blade type of stem, and then you can't actually put in the smallest available other company stem. So sometimes you're forced. And also the third issue is like if you are using a very small cemented stem like an Exeter or a CPT 00, we must make sure that we can't leave it proud, because otherwise it will break. The problem with that is sometimes with the largest available head also, you'll not be able to restore the correct length and offset for the hip. So stability becomes a third concern. And fourth is, what is the version of the cementing? Is it acceptable for the combined version of the patient? So these are all the four factors. But if it's a young patient, very well cemented situation in the cement bone interface, version is decently okay, then it's the first choice, because you are now retaining the host bone.
So I think that line is very clear. So if you're retaining host bone, cement mantle is good, version is acceptable, go ahead with cement on cement. But otherwise, younger patient, you need to change the parameters, go ahead to revising the stem or revising the fixation. Correct, Krishna?
Yeah. You must be prepared to do a ETO if required, and must also have the equipment to do a endofemoral removal of cement wherever it is possible.
Correct.
And I think the thing to take home is here, if your stem is fine, but you got to do a last thing on the cup, but the stem is coming in way. So you basically knock it out and put it back.
Yeah, and provided the parameters and everything that you can restore are within the fixation that you're going to be permitted with the cemented cement. Yes, Rakesh, very well. Any other points? I think we're looking at the chat box now. Rajiv, you let me know when it's the 6 minutes are done, right? So the chat box while using cement, there's no other questions in the chat box that I can see for now. I think Adarsh had a question a little early on. Okay, Krishna Raj Kanal, any changes in approach in a patient with rigidity or spasticity, for example, due to Parkinson's or stroke? Who would take that on?
Dual mobility.
No, I think any changes in approach. I think that referring to Krishna Raj was referring to the surgical approach.
Generally, the norm is to use what approach you're familiar with. I don't think you should change approach for.
I think you should change that. And if it's with respect to the fixation, you're saying dual mobility. So approach, whatever you're familiar with, fixation, you would suggest dual mobility. Okay.
If it's posterior, you must repair.
Posterior, yes, Ronan?
If you use a posterior, you must repair.
Repair, okay.
Anil, I have a question.
Yes, Rakesh, go ahead.
I was listening to Suri's talk, and one of the things he suggested for preventing further dislocations is to put a larger head. I just want to ask people who are doing some sort of anti-approaches, how useful that is for your approaches?
Not at all.
A larger head.
Because see, your head is ultimately dictated by the established size. So there is an
upper. If you can put in, I mean, how much of a usefulness that is to prevent dislocation?
I think more than the head size is getting the parameters right. Correct, Krishna?
Direct anterior approach, we found that even with a 28 mm head, the stability is the same. So we don't use any dual mobility if you are using a direct anterior approach. All this come into play when we are using the posterior approach. So for primaries where we are doing direct anterior, instability is almost gone out of the picture.
So Anil, that's what I was actually saying, that if you do like one of these anterolateral or anterior approaches, then putting larger heads actually doesn't help you too much. And in fact, if you do things like dual mobility, sometimes it's very difficult to do trials because you can't get the trials out.
What's the lowest size of dual mobility?
So Ronan, this will be last questions.
What's the lowest size of dual mobility? I think you start from 30. Krishna, Evolutus starts from, I'm using a company name. Evolutus starts from 30, 40, I think 41.
46 is there.
See, they don't have it in India. They have the symmetric ones.
46 is what I got. That's 44, the problem that I had in my case.
You have 44 from Evolutus, you have 44 from...
No, Striker is from 44, 46. But I'm talking about Evolutus has smaller sizes because it's a cemented one.
The 43 is available.
Yes.
But they don't have 43 in India. They have 45 onwards.
Okay.
What Evolutus?
Evolutus
has 45 onwards. But most companies, Merrill has 44, which say modular dual mobility, and also Accolade Trident has got 44 onwards.
Yeah, Striker got 44 onwards.
Anil, I think Depu has 43.
Depu has 43. Have they launched? And Bimentum you're talking about? They've not come into right.
OR30 is there from Smith & Nephew. Just got an oxenium on poly.
We are 1 minute crossing our 2 hours limit.
Okay, sure.
Maybe we can have the concluding remarks.
Okay. So, okay, what I can say quickly, thank you so much. I think dislocation would be a topic that we can go on discussing, but I think today we had some very good points. Thanks, Krishna. Thanks for all who joined. Ronan, Rajiv, I think Suri had some words of wisdom. We had a good discussion. I think, Rajiv, the take home is that we should have one more on dislocation. I think even then we won't complete.
So this was a very interesting subject. And very well taken up by the speakers. Ronan, would you like to close the webinar now?
Yes.
Well, thank you, Rajiv, for organizing this with the IOA. It always helps to have a larger banner and increase the footprint of both IOA and IA. And I'd like to thank Anil for organizing this at such short notice and for having such a wonderful evening. And thanks everyone for taking part. And we look forward to seeing you again soon. Thank you so much.
Thank you, everybody.
We can close it without sending the invitation for our forthcoming IACon 2023 at Chandigarh.
Exactly. That's just about a week from today.
13th, right. 15th October.
Right. So thank you so much.
See you in Chandigarh.
Thank you, panelists. Thank you all. Thank you all for joining.